Okay, so for our lecture that we did not get to talk about the other day, we are going to talk about the P's of labor. So this whole unit is going to be about, well, one, we're going to add in our RH incompatibility. We're also going to add in our blood pressure disorders. But for the rest of the unit, it's going to be about labor and postpartum complications, and so forth. So to introduce our labor, we are going to talk about the P's of labor. So the first P that we're going to talk about is passageway. Passageway is our pelvis, so mom's pelvis type. So there are 4 different types of pelvises, and our one that is the classic female pelvis is called the gynecoid. Gynecoid is spelled Gynecoid, gynecoid. That is the classic female pelvis. This is our most favorable pelvis type for a vaginal delivery. Our next type of pelvis that we have is called the android. Yes, like the phone. This resembles the male pelvis. The anthropoid is our next type of pelvis. It's the most common in, or one of the most common in men. It's not as good as the gynecoid, but if we had to have another type of pelvis for a vaginal delivery, we're going to pick the anthropoid. Anthropoid is spelled Anthropoid. So then our last one is called the platypoid. Platypoid is Platypelloid. This pelvis we cannot deliver vaginally because it's very flat. And then our android pelvis, we cannot deliver vaginally with this one because it's also very narrow and it's shaped like a heart. So the 2 pelvises that we can deliver vaginally with is the gynecoid and the anthropoid. And if I'm going too fast, you have the pause and you have the rewind, so just keep that in mind whenever we're going through this. That way your video is not like 2 hours long. So this is all about our passageway. So passageway, hopefully we have the gynecoid, classical female pelvis. Baby will fit through that. We like that. Another thing that next we're going to talk about fetal presentation. So fetal presentation is how the baby is presenting in the birth canal, so in the pelvis. So is baby cephalic, breech, or shoulder? Cephalic is all about head. Are we head down? Obviously, this is the way that we want baby to come out. If we are breech, this means we are butt down. We do not want mom to deliver breech. This could lead to fetal head entrapment, which could lead to fetal death. So try not to deliver breech. It happens in in cases where we can't stop labor and baby just comes out, like our precipitous deliveries. So if we identify mom as breech, she will be a C-section. And then shoulder presentation, I'm sure you've heard of like a shoulder dystocia. This could cause our difficult labors or our dystocia labors, and we cannot deliver this way either. So if baby is in a cephalic position, they are normally in the vertex position. So cephalic and vertex. Vertex means that we are chin to chest. So baby should be tucking and basically tucking and rolling through the birth canal. If baby has brow presentation, that means when baby's coming out, we mainly see brow and this forehead. If baby has face presentation, that is whenever they are coming out and we see face. And then chin is whenever they are hyperflexing their neck. We talked about this in simulation. I'll bring in the baby again to lecture and I'll demonstrate what this looks like. So whenever we talk about presentation, this helps us with our letters. So letters will help us determine what fetal position is. And everyone that has came through simulation has heard the spiel about LOA, ROA, LOP, and so forth. So our first step is baby right or left? So the way that baby's face is facing compared to mom's abdomen, I didn't say this right. The way baby is facing, so which way the baby's face is whenever mom, if you were in mom's body, which way is baby facing. So if baby is facing this way, which I think this is mirrored, so I am looking to the right. This is right, and then this is left for baby, which we talked about this in sim, so I'll demonstrate again with the baby at lecture. So right or left is your first letter. The second step is, are we O, S, M, or SC? So O is occipital, S is shoulder, S is sacrum, sorry, SC is shoulder, and M is mentum, which is chin. Obviously, we want to be in the occipital position. If we're in the M position, which is mentum, it could cause a lot of strain on baby's neck, but doctor could hopefully manipulate the head and get them out of that position. S, which is butt, also known as breech, they have to be delivered C-section. And then SC is shoulder, and we should not be delivering that way either. Then our third step for our letters is, are we anterior or posterior? So like I told you guys in sim, what we are looking at is back of baby's head. Where is back of baby's head? Is it facing abdomen? So you feel it, and it's facing up towards mom abdomen, and that is known as anterior. Or is the back of baby's head facing down towards mom's spine and tailbone? That is posterior. Remember, we do not want them in the posterior position because it causes lots and lots of back labor for mom. So with this, we're gonna have to provide that firm sacral pressure, or have our supporting partner, do this as well. So we would really like to see our babies in ROA or LOA. These are our most favored positions for delivery and baby's position. I hope this is making sense. Sorry, this is hard without a whiteboard. Station is next. So how baby is compared to the ischial spines. So this isn't something new that you've heard because I've told all of you this in simulation. The ischial spines, once again, is the most narrow part of the female pelvis that the baby has to fit through. So if baby's head is in line with the ischial spines, baby is at 0 station, also known as engaged. Then if baby's head is above the ischial spines, that means we have a floating presenting part and we are in the negatives. So that means we're not engaged yet and baby has not came down, so baby is still floating. If we are in the positives, that means we are past the ischial spines and we are positively coming through the birth canal, which is a good thing. We like that. So what is so important about this? We want our babies to be engaged before we get mom up and walking. If she's up and walking and she's in the negatives and her water breaks, the cord could slip, and that's known as a prolapse cord. That is a safety thing. Your baby could die. So we don't want that. That's a safety issue. It could go against our license. So mom has to have baby engaged before she can get up and walk. Now, if mom is a +4, +5 and her water has not broke, don't get her up and walking, because yeah, she's past that engagement, but that water could break and you could be having a baby. So don't get her up and walking then either. We either like engaged or +1, +2. After that, try not to get her up and walking that much. So reminder about our sutures and fontanelles. We talked about this with peds, but we have our anterior fontanelle and we have our posterior, and when those close. And then our sutures, those are our bones that are in our head and our skull. They're not fused together. And we like that because our head can mold and fit through the birth canal. Sorry, let me get through this and see where we are. Okay, and then we have our next P, which is known as powers. So powers are known as the contractions. So contractions, if you are having a true contraction, you should be having dilation and effacement. So dilation means how wide the cervix is opening. If you are fully dilated, you are 10 centimeters dilated. Effacement talks about the cervix. So if you were at sim with me on Thursday, I already made a joke about this, but on your exam, if you put a long, thick cervix, that answer was wrong. We want moms to have a long, thick cervix during pregnancy, but during effacement, your cervix actually starts to shrink down and it's kind of like a pancake. And we want that. We like a long, thick cervix because that means she's less likely to abort the pregnancy. But whenever we go into true labor and have true contractions, that starts to sandwich down, and that's known as effacement. We are fully effaced when we hit 100%. So if you are complete, you are 100% effaced or 10 centimeters dilated. So to have a true contraction, they say that you feel the pain radiate from the back to the front. So your lower back, and it goes to your abdomen, and you feel these. And they get worse if you're walking. Nothing helps them, like resting, nothing helps them. They just keep coming. If you are having Braxton Hicks or fake contractions, and you tell mom to lay down and rest, drink a cup of water, and she says, oh, they went away, that's Braxton Hicks. If you are having true contractions, they don't go away, and they're causing cervical change. So with a contraction, if you're having true contractions, you are going to talk about them with frequency, duration, and intensity. So frequency is how often they're happening. So I'm having contractions every 3 minutes. So you had one, and then 3 minutes later, you had another. That's what frequency means. Duration is how long they're lasting. So the duration is 40 seconds. Your contraction is lasting a whole 40 seconds on that strip. And then intensity, some people ask me this at sim on Thursday, I'm pretty sure, is what does the numbers mean on the contraction about how high it goes? That is supposed to be the intensity of the contraction. So that is like how far it is and how it feels. If we wanted to sit and measure this on mom, sorry. Beckham, mommy's doing her lecture, okay? If we wanted to feel the intensity ourselves and manually palpate it, they say a mild contraction feels like the tip of your nose. They say a moderate contraction feels like your chin, and then a strong contraction feels like your forehead. So that kind of explains intensity a little bit. So now that you're poking your nose, let's talk about let me get my thoughts together here really fast. We talked about true contractions. Let's talk about pre-signs of labor. So these are things that mom is going to go through. So this is kind of another P. It's called the psych of labor. So this is what mom is going through. So if you've ever heard the term lightening, that means that your uterus that was up here and had all your organs shoved up to your chest has now started to move down, or also known as baby's dropped. Lightening happens when that uterus starts to go down and everything starts to settle in the pelvic area. They say that this can happen at least 2 weeks before you have your baby. Mom is going to say, I'm less short of breath. I don't have congestion anymore, but now I have to pee all the time. My back hurts. That's normal. Mom may also have something called bloody show, and this is her losing her mucus plug. So mucus plug is, like we talked about, it's kind of like our cork in a cork bottle, or in a wine bottle, cork in a wine bottle, and it blocks stuff from entering into the uterus. Well, she will slowly start losing that, and that's because she's having cervical dilation. So think of it, if this pin is her mucus plug and this is her cervix, once it starts to dilate, it starts to slip out. So your book says something about if they lose this, they're gonna have a baby in 24 hours. That's pish posh. Everyone loses it differently. Some can lose it at the beginning of the third trimester. Some can lose it right before they have their baby. Everybody's different. Some moms may have rupture of membranes. That's where their water breaks. And remember our job with that. We talked about this with preterm labor and prom. If their water breaks, we just note the time, the color, the amount, did it smell, stuff like that. They may have a sudden burst of energy. This is where they go into those nesting behaviors and they start cleaning the house, painting walls, building a crib, all those fun things. They may have some weight loss. Weight loss is where they are going to lose 1 to 3 pounds. Hey, mommy's talking. They could lose 1 to 3 pounds, and that's due to electrolyte shifts. Hang on. Okay. So they may have a weight loss, and that's usually about 1 to 3 pounds. And they say that this is because electrolyte shift. It's also caused by estrogen and progesterone shifting too. And mom may also have lots of diarrhea, nausea, vomiting, and all the fun stuff that comes with going into labor. So we talked about true versus false contractions. So if she is having true contractions, then we are going to say that she is in the stages of labor. So there are different things with this, and this is very important. So if you take anything away from this video, please take this with you. So stages of labor. Beckham, be quiet, buddy. Stages of labor, we have the first stage. This is from start of labor until you are complete. So 10 centimeters dilated, 100% effaced. There are 2 phases that go in stage 1. That is the latent phase and the active phase. So latent phase, your book is going to say something different than what I say, but so there's no confusion, we're going to change it and you're going to listen to what I say, okay? Latent phase is whenever you go from 0 to 5 centimeters dilated. Your contraction frequency is every 5 to 10 minutes. They are lasting 30 to 45 seconds. In your intensity, they are mild. The latent phase is very important because this is where you need to be doing all of your education. So education is like what happens when you start pushing, so whenever you're complete, or what happens when the baby's born, what would you like to happen, and all this stuff. Another one is moms start to lose control in the active phase, which we're going to talk about that in a second, and we kind of have to bring them back to earth a little bit, like have it coming to Jesus. And if they are not complete and they try to push, it can cause a lot of damage and pressure on their cervix. So if they are 8 or 9 centimeters dilated and say, I have to push and I'm going to push, we need to teach them to blow out the candle. So cleansing breaths, all the things. Because if you say, hey, don't push, she's going to give you the big, cuss you out, finger, all the stuff. She's not gonna like that. So we're gonna teach her before we get to that stage or phase. This is what you do. So then your active phase, this is whenever you are 6 to 10 centimeters dilated. So you're contracting every 2 to 5 minutes and they're lasting 45 to 60 seconds. And the intensity is moderate. So with this is where things kind of get crazy. So things are getting real in this phase. This is where her water could break. This is where she could possibly be asking for an epidural, which she is more than welcome to have an epidural whenever she wants. But keep in mind, we technically do not keep moms until they're 4 centimeters dilated. So if you come in and you're kind of contracting, but not really in a good pattern, and you're 3 centimeters dilated, we could send you home. So she could get the epidural. There really is no cutoff on getting the epidural. The biggest thing is, like, if you're a 9 and you're sitting at the side of the bed, we really don't want you to have a baby at the side of the bed. So we got to really be thinking about that. And then if mom doesn't want the epidural and wants to just do like no pain meds or the morphine method, then we cannot give morphine after 8 centimeters because it goes straight to the baby and it could cause respiratory suppression. So we don't want that. So then the second stage of labor, so we're out of the first stage now in the phases. Our second stage of labor is where we go from complete, so 10 centimeters dilate, 100% efface, to birth a baby. So now we have a baby, yay, all things are great. And then we go to the third stage, which is where we deliver the placenta. And we'll talk about this in postpartum, but we have 30 minutes after babies got out to deliver our placenta. And then the fourth stage is postpartum. So they say postpartum is from postpartum or after delivery of baby and all that to pre-pregnancy state. So, keep moving through here. Our next thing we're going to talk about is how mom responds to labor, like how her body changes. So we talked about body changes during pregnancy. This is going to be body changes for labor. So our heart, our cardiovascular system, our heart rate is actually going to increase more, so 10 to 20 beats per minute more. Our cardiac output will actually increase, and our blood pressure is going to increase. Don't get hung up on numbers here, okay? Our respiratory changes. She's going to be breathing faster, which could her respiratory rate is going to be faster because she's going to be like, I'm pushing, I'm doing this, and all this fun stuff. That could lead to hyperventilation. So we have to be very careful with this because it could lead to her being hypoxic. It could lead to respiratory alkalosis, and we don't want that. Let me flip my notes here. Her white blood cell count, remember we talked about in pregnancy, that white blood cell count is normally high. When she goes into labor, it could be as high as 25 to 30. If we start getting like over the 40s, that's when we're concerned because then she probably has an infection going on. So we got to be really careful when we watch this. She is going to have slow intestines, so she's going to be constipated. Very normal. Her temperature is actually going to increase. Normally it's in the 99s. If we see anything over 100.7, that's when we're like, ooh, you're running a fever. We don't like that. And then we'll talk about this later, but actually when mom starts running a fever, baby's heart rate increases. And I think that is all that we're going to talk about because I don't want to give away too much. And then we can review this on Tuesday. I really do apologize because I'm not ever sick. So, well, I am sick, but I don't ever leave class early. So this is very frustrating on my end, but I hope this helps. Reminder, like if you feel like something didn't make sense, back up, rewatch it, and I'll answer whatever questions that we have on Tuesday, and then we'll go through the rest of our content. But reminder, we only have 2 days to get through this content, and then I'm hoping that maybe we can have like a review day after ATI Live Week to kind of prepare or talk if you have any questions in your study. And then the Tuesday before you take your exam, we'll do another review. So, all right, I hope this helps, and I hope you guys have a great weekend, and I will see you on Tuesday.